So I thought we would talk a little bit this morning about a study that was done in Marine recruits that I think is instructive in understanding a little bit more about transmission in congregate settings, particularly among young people. So I think we discussed the fact that the study was out there a bit, but it was published in the New England Journal last month, conducted by former colleagues of mine at the Naval Medical Research Center. But this, we have not done a deep dive into this study, and I think it's, again, instructive in looking at transmission in some of these settings. So this was a study that was done at Parris Island, which is the East Coast Marine Recruit Depot, and it was done mostly in May, a little bit in early June, so very early on in the pandemic. And if you remember, in South Carolina in May, they had relatively, actually quite low rates of transmission, so did relatively well. And they were able to recruit essentially 60% of the eligible young recruits coming into to boot camp. So keep in mind that the vast majority of these recruits are 18 right out of high school. A few are 17, which is why some weren't eligible, and there's a smattering that are a bit older. At the time, because of the pandemic, the Parris Island protocols had been adjusted considerably, and so what they were doing is taking recruits and asked them to self-quarantine at home for 14 days before they even showed up at Parris Island, and then had done a second supervised 14-day quarantine period at a local college campus before they ever brought them on to Parris Island, the recruit depot. So this study actually followed those Marines during that 14-day supervised quarantine on campus. During that time, the Marines were broken up into platoons of 50 to 60, and that's who they spent the majority of their day with. They had very aggressive infection prevention control protocols in place. Essentially, all the recruits wore masks, and the instructors 100% of the time for all activities indoor and outdoor other than eating and sleeping. They had a single roommate. They had double rooms within the hallway. They shared bathrooms. Platoons mostly stayed in the same hallway together, but multiple platoons were in hallways together. So the hallways and bathrooms were not platoon specific. Almost all of their activities were done outdoors. This was early summer in South Carolina, so that's possible. And they had very aggressive sanitizing and hygiene practices. They had chlorine wipes that they used each time they used the bathroom or any facility. They had hand hygiene stations everywhere. So about as good as you could get in terms of IPC practices. What they found is that day zero in these roughly 1,800 Marines that they investigated, almost 1% were positive by PCR on the day they arrived. None of those Marines had IgG antibodies, so presuming that these were early acute infections. Of the entire cohort that they tested, that 1,804 or 0.2% had pre-existing antibodies. So that would probably fit with the background rate in the majority of Americans in May, as long as you were outside of one of the high prevalence areas. And then what they found over the course of the 2 weeks is that, from 16 positives on day zero, they went up to 51 positives, so almost 3% by day 14 in the study participants. And then in the non-participants, part of the protocol was everybody got a PCR at the end of that 14 days before they were let into the actual recruit depot at Parris Island. And so they found essentially 2% of the non-participants were also infected by PCR at that time. The other thing to note here is that the concordance with roommates was incredibly high. So if you had a roommate that was positive, that was a very predictive condition for your being positive. Looking at the PCR results for a few of these positives on day zero that they followed, I think it's instructive to see that some of them follow what we would expect with acute infection. They were high initially and then went down, but some had relatively persistent levels of, in terms of the CT cycle count on PCR, which indicates how much virus there is present. So if you look at 1505, that marine is positive. Those black pluses mean PCR positive, and those curves, the different colors are different genes in the PCR target. And you can see essentially all of those CT values are in the mid to high 20s. So those are CT values which have been shown to be consistent with the ability to recover viable live virus. And so that's somebody that I would consider potentially transmissible even across the full 14 days of that illness. And you can see looking at day 0, they were probably positive for a couple of days before that, and we don't know after. So, this idea that people are only infectious for 10 days, I think this, among many other data points, indicates that that is not always the case. I think 1601 is another example where you have somebody that looks as if this is a more classic profile for their viral load. We probably picked them up very early on day 0, and then they had increasing titers, actually developed symptoms on day 7, and then by day 14 were low, but still around a cycle time of 30, so potentially transmissible. And then again, 1963, another person who's shedding virus for at least 10 days at high levels, if not longer. So in a small handful here, you can see there's already a few that look as if they would be infectious for longer than 10 days. These are participants who were positive initially on day 7, so presumably acquired their infection once they arrived. And these look a little more like what we would expect from other data. The other things that I think were interesting to look at is how clustering happened. So they actually ended up sequencing about 36, I think, of these positive specimens that they got. So they were able to do the actual genomic epidemiology to tell whose infections were related to whom, because they can see what viral mutations they had and cluster them together. And you can see there were 6 identified clusters among the sequences that they, among the viruses that they sequenced. So the majority of transmission events occurred in clusters. 2 of them were relatively big. You can see clusters of 9 each. And many of those, 6 in one of those clusters, 4 in the other, involved an infected roommate. So roommates, again, appeared to be a significant risk factor. But when you looked at these clusters, these are the 2 9-person clusters. It's interesting, while there was a lot of roommate infection and concordance, there were a number of people who had only a single person infected in a room. Roommates were not infected, and you had this hallway where multiple platoons shared a bathroom. But again, there seemed to be little overlap between the platoons. Again, the cluster in platoon E and the cluster in platoon F seemed to be relatively confined to those platoons, with the one overlap of this one person here in platoon F who actually had the virus that was associated with the platoon E cluster. But for the most part, even though living conditions were quite close and shared, your cluster seemed to be more correlated with what platoon you were in, so who you shared activities with during the day. And remember, these are Marine recruits, so they are doing lots of physical activities outside, even though they were maintaining 6-foot distance, potentially at all times, or at least supposed to, and wearing masks. Transmission within those platoons seemed to be more related to who you spent most of your time with during the day and who you slept with in the same room at night. Now remember, these platoons ate together, so that was the one time when they had masks off other than sleeping. And so that might explain why platoon clustering was so prominent. So I think some of the takeaways from this study, first of all, a 2% attack rate over 14 days is actually a pretty significant attack rate when you think about it. That equals about 180 cases per 100,000 per day, which is well above what we're experiencing and above the peak of Douglas County. Some counties in Nebraska experience that rate. But early on when they brought these folks together, even with all of the precautions, when you have a group living together in those close quarters and eating together and spending all of that time together doing physical activity, that still provides opportunity for virus transmission. I think the other thing to note is, I think I glossed over it, but fewer than 10% of the positive Marine recruits were symptomatic. So symptoms were essentially a dramatic exception rather than the rule, and no symptom screening was able to identify anybody with a positive PCR. So again, shows that these kids, again, most of these kids were in high school a month before, or 3 months before this started. Um, most of these kids are completely asymptomatic and are able to transmit disease quite effectively in an enclosed population. And then again, we mentioned that the infection clusters appeared to be associated with what platoon you were in rather than who you shared a hallway or bathroom with. And the other exception is roommates were obviously a high risk population. And then finally, one instructor was also infected by the students. Now, these instructors spent their entire time on campus. They weren't allowed to go home. They didn't go out in town. They were sequestered on campus with the students. So this instructor was infected by one of these students and not by somebody in the community. So again, spending lots of time with somebody, even if you're all masked. Again, we know masks are not 100% effective. And you have to take them off to eat. So all of these things contributed to these clusters of transmissions within these recruits. So I think that's, again, very instructive and particularly probably relevant to high school scenarios in the US, where density and proximity among those students is pretty similar to what we saw here, and take away the rooming situation. So that's all I got.